So, good morning, Michelle. Thank you for doing this with me.
Good morning, Shirley. I'm very honored to be invited to work with you.
I want to jump right in. I'd like us to start with a conversation that's so meaningful to a lot of women in the menopause chicks community. And I don't believe enough menopause conversations start with this. Okay, are you ready?
I'm
It's
anticipating what it's going to be.
changes to bleeding and specifically heavy bleeding. We do not hear this in the media. This is not part of the narrative from marketers. They're always trying to fix something else. Would you start us off by talking about heavy bleeding, please?
100%. And this is like first principles. Any gynecologist in your community should actually know how to deal with your heavy perimenopausal bleeding. This does not take the expertise of a menopause specialist like myself. Perimenopausal bleeding happens for a number of reasons. The one that concerns doctors and is important and why you shouldn't ignore it is when you get closer to menopause and the number of available eggs you have decreases, you don't ovulate every month necessarily. That's sometimes why you get your periods spacing out more because you're not ovulating regularly and predictably. But what it also means is that you're making estrogen from lots of different parts of your body, including the ovaries, but also including the fat cells. And if you're not ovulating and making progesterone from ovulation, you are effectively being exposed to unopposed estrogen. And unopposed estrogen is why you can't just take estrogen hormone therapy without an endometrial protective agent, because over time it will lead to the lining of the uterus becoming thicker and bleeding unpredictably. And over time after that, precancerous and cancerous. So
Right.
that's why heavy perimenopausal bleeding really needs to be investigated. And optimally, that would be investigated with an ultrasound, with sometimes a special kind of ultrasound called a sonohistogram, where water is pushed into the cavity of the uterus to look at the structural lining of the uterus, and ideally some form of a biopsy or a DNC where some tissue is actually removed and tested, which can help guide your treatment, but also is very good at making sure that there isn't any cancer or precancer.
And gives you a baseline
Gives
for,
you a baseline, but also in some tricky cases, and this is more what I do in my area of expertise, checking a biopsy and looking at the hormonal profile of the tissue, which is something most doctors don't do, is a way that you can target and change the treatment that will be more likely to work. Because everyone just assumes if you're bleeding, you probably need more progesterone and less estrogen. That is not always the case.
so what's on the menu for treatment options?
Great question. So there is an algorithm called Palm Coin, which is maybe the dumbest algorithm ever made because it doesn't actually make sense, but it divides causes for bleeding into structural and functional causes. And the ultrasound and the sonohistogram are going to be the investigations for the structural causes. Palm stands for polyp, adenomyosis, leiomyoma, which means fibroid, or malignancy, which also means pre-malignant or pre-cancer. Those are the things that you need to know if they exist, because if they do, they usually should be treated surgically in order to fix the problem. Then COIN stands for coagulopathy, ovulatory problems, those kinds of problems, problems with bleeding. Those are going to be more functional or hormonal problems. And so the treatment approach is really going to depend on which of those arms is causing a problem. Is this something surgical that we should deal with surgically, or by treating the fibroid, or by cutting off the blood supply to the fibroid or the uterus? Or is this something that can be treated with medication to slow bleeding, like tranexamic acid? Non-steroidal anti-inflammatories, which if taken properly, like Advil, can can lighten the amount of bleeding by up to 50%? Or are we moving into the world of hormones? Birth control pills, IUDs, hormone therapies, medications that put you into menopause and then give you add back hormone therapy. Those are going to be the ways that you can treat dysfunctional bleeding that isn't due to an anatomic cause.
Right on. Thanks for mentioning the Advil. I learned about that years ago, and it has come in handy for women who are like traveling and they get surprise heavy bleeding, and it can work.
Yeah, like pretty much, I mean,
Until you
barring
get back
any
and can check with your healthcare provider.
100%
Yeah.
good point, but you're right. Like there are a couple medications like ibuprofen and like tranexamic acid that if you bring with you when you go on a vacation, and you can use tranexamic acid for lots of things. My husband used it for a nosebleed the other day. You
Oh,
can use it for a bad gum bleed, and you can certainly use it for a heavy menstrual bleed. There are very few contraindications, which means reasons why you shouldn't take it, and it will help to slow your bleeding tremendously. The way you do it with the ibuprofen or Advil is you start to take it as soon as you can tell the bleeding's about to start or when the bleeding has started. You don't wait for pain or cramps. You
okay.
take it regularly around the clock for 2 or 3 days. It will lighten the flow by 30 to 50%.
That's amazing. Okay, you mentioned another common topic, and that is fibroids. So I think we are generally, confused about the message around fibroids. Will they disappear post-menopause? Is it a wait and see game? When do I need to be concerned?
Great questions. So remember that fibroids are common and they are almost never cancer. They can be, but it's very rare, like one in a
It's a
thousand.
nice, comforting
Yeah.
message.
Yeah, because otherwise, everyone who gets an ultrasound for one reason or another is going to think, oh my God, what is this? They said it was a tumor. Tumor doesn't always mean cancer, and fibroids are certainly usually not cancerous. That doesn't mean that they can't be bothersome. And when you think about the reasons fibroids are bothersome, again, you can sort of divide that into three categories. Are they impeding your fertility?
Uh,
Are they causing heavy bleeding? Or are they causing bulk symptoms where you're getting problems with your bladder or feeling bloated all the time or back pain because of how big and the location of the fibroid? So fertility is probably, something that our menopause chicks are beyond worrying too much about at this point. But when it comes to heavy bleeding, even the smallest fibroid that is in the cavity of the uterus, location, 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 can cause tremendously heavy bleeding. The sort of opposite side to that is even small fibroids in in the wall of the uterus, like underneath the top lining or in the muscle wall. They don't tend to cause any trouble at all. And sometimes you can have very large fibroids, 30 centimeters, 20 centimeters, that are going to make you feel like you're pregnant. Again, they're not dangerous, but if they're impacting your quality of life, if they're compressing your kidneys and causing swelling, if they're causing you to have bowel problems, back pain, bladder problems, those are all reasons to consider removal or trying to shrink the fibroids. Not everyone needs to have their fibroids removed.
yeah.
If you try and have your fibroids removed, most of the time, if you're past your childbearing years and you're not intending to carry a baby anymore, it is safer to consider removing your uterus with the fibroids than it is to try and cut into the uterus and remove each fibroid one by one from a bleeding, infection, regrowth of fibroids perspective. It might seem really aggressive, like we're going to go in and take your uterus out because of these fibroids. Most people do not need to have this done, but a lot of people wonder, can't I just take the fibroids out? It is actually more dangerous to just take the fibroids out, especially if there are many. There are also options like cutting the blood supply off through an interventional radiology procedure, or if the fibroids are in the cavity of the uterus, we can just go in with a little camera, like a colonoscopy, but of the uterus, and remove the component of the fibroid that is in the cavity of the uterus to help with bleeding problems. So there are lots of options. They don't all result in something really dramatic, and most people could just ignore their fibroids because most people don't actually have problems with them. They will not disappear altogether. So
Oh,
when you go
okay.
through menopause, so perimenopause is a time where your hormones are fluctuating and you can get quite high levels of estrogens and sometimes progestogens as well. And these fibroids are very hormone sensitive. So they do tend to grow a little bit in perimenopause. Then they tend to shrink if you're in menopause, even if you're taking low doses of hormone therapy, but they will not go away altogether.
Okay, thank you for that. So, before we move into the next phases, what is one message that Dr. Michelle Jacobson would have for women in perimenopause?
I think my one message is that your symptoms and your experience in perimenopause counts,
Mhm.
even though you might still be getting your period. So often women in perimenopause will go to their doctor, their nurse practitioner, whoever their primary care provider is, and even their gynecologist and say, I just don't feel like myself. I'm not sleeping well. My mood is low. I feel anxious. I'm irritable. I wake up in the middle of the night and I can't fall back asleep. And the doctor says, well, you're getting your period regularly, so this isn't hormonal. And that is absolutely not true. We know that women start to experience perimenopausal symptoms sometimes 10 years before their final menstrual period. And in the early perimenopause, this can even mean regular periods or periods closer together. Treatment for perimenopause follows the same course and recommendations as menopause, except with some small sort of changes where I like to start people low because I know that your need for hormone replacement may increase as your ovarian reserve decreases. But I really urge you not to be sort of put on that pathway of believing that this can't be perimenopause because you are getting your period. It is
Right.
absolutely not true. And that's part of the type of question and the type of care that Coven is trying to give, because we know that this is what women feel. They feel gaslit, they feel abandoned, they feel confused, they're getting a lot of misinformation. It is so important to us at Coven to be able to be evidence-based, but also make women aware of their options and treat them in a way that is going to improve their quality of life and their functioning and be safe.
That is so beautiful. You have just nailed it. Something I have talked about for years and years is I will meet women and they will either say, whoa, Shirley, I'm not there yet. And then I meet women who will be like, oh, been there, done that. This doesn't apply to me. And so, how you just articulated that for women in perimenopause, I think, is opening up such an incredible investment opportunity.
I agree. Like perimenopause is a really, really hard time. Your symptoms may not have read the textbook. Your bleeding may be all over the place for the reasons that we talked about. You might still have concerns around not wanting to become pregnant or wanting to become pregnant. So contraception options or being sexually active, they're all sort of under this cloud of worrying about being pregnant or not being pregnant. And then you're also having menopausal symptoms and people are telling you they're not menopause because you're still getting your period. This is one of the hardest times to get the treatment that you deserve, and it's your podcast, your group, this education, the work we're doing. I think that is bringing the awareness to perimenopause that it needs.
Well, I was going to ask you because we're all dealing with a lot of noise right now in media, marketing, and even from the medical community. What you think of that and what do you see as the biggest opportunity for us right now?
Well, I think that women are talking about this. Obviously, women are not really willing to take no for an answer or say,
Right.
I'm not just going to take a sleeping pill or an antidepressant because I'm 41 and getting my period, but really not feeling well. So, more and more research is being done into this. People are talking about it. Unfortunately, and I have a little bit of chagrin for the medical community, we are sort of the last to follow in terms of getting with the program. So you, as the consumer and the patient, really do have the power that if you don't feel that your questions are being answered or that your symptoms are being attended to in the way that they should, there are infinite opportunities for you to seek the kind of care you deserve. And since COVID, there were a few good things that came out of it. All of this virtual care has made access to the type of care you deserve and specialist access so much easier. Coven is fully virtual. The purpose of doing this is we want women who are not able to access a menopause specialist in their rural community to be able to talk to, again, somebody who can offer them evidence-based care that is not gaslighting, that understands that perimenopause is a confusing time where the symptoms are really bothersome and yet there's so little out there. So, I think this is an exciting time to be perimenopausal.
Absolutely. Access to care that we deserve. That's beautiful, beautiful. Okay, so let's fast forward to someone who is, I'm going to say 61, and her last period was 3 years ago. She has been on this journey and she is assuming that, oh, I could handle it. It wasn't that bad. maybe a little white knuckling through a couple of, sleepless nights. And then she wakes up on her 61st birthday and she's like, huh, I get all this messaging that I could have or should have or would have if I had have known better. Can you speak to the 61-year-olds in my community and shed some light on what you see as our biggest opportunity for our next, let's say, 3 to 4 decades?
100%. And it's a great question because, again, these women in their 60s are sort of being abandoned from the menopause freight train because everyone is now happy to be prescribing hormone therapy, but not if you're over 60 or more than 10 years from your final menstrual period. That is the messaging that
That
we're getting.
or is so important to
The
me.
or is so
Or is so
important
important
because
to me.
this 61-year-old, first of all, fits into the or category, which means the reason we talk about initiating or starting hormone therapy as being during a window of opportunity is that the lessons we've learned from big studies like the Women's Health Initiative showed us that when women are without hormones like estrogen for a prolonged amount of time, like 10 years, this is an opportunity for plaques and blockages called atherosclerosis to develop in the lining of the blood vessels that go to the brain or to the heart. And if you then start estrogen therapy, once those atherosclerotic plaques and blockages are there, you break off little pieces of plaque and cause clots like a heart attack or a stroke. So, this is the concern with starting hormone therapy when atherosclerosis is present. The or comes from if you have had estrogen around until 58, like in this situation, and we now have a 61-year-old, she actually fits into the criteria for someone who is eligible for hormone therapy because she is not 10 years from her final menstrual period. Now, that's not to say that if she's had 3 heart attacks in the interim, that she is a good candidate, right? Like we are not making blanket statements, but I think the point is that all conversations should be individualized, and guidelines are meant to apply to large populations and help guide people who are novices in prescribing menopause management to make safe choices. There is always room for further discussion, for further investigations to determine if somebody is a good candidate or if the risk is going to outweigh the benefit or vice versa. And at the end of the day, you as an adult are also very responsible for your own medical decision making. Who are we to withhold treatment that might improve your quality of life because of studies that may or may not even apply to you? So I think, again, if you are 61, 3 years postmenopausal, healthy, and suffering from symptoms, if you saw me, I would certainly give you hormone therapy if there was no other concern. I think you may get pushback from a lot of people who are just beginning to prescribe. But again, this is why there are other clinics, second opinions, menopause specialists.
Absolutely. And it's why I think women now are gaining that agency, that vocabulary to be able to say, oh, I understand that's a guideline, but it's not a deadline. So can we talk about me and what the
Right.
benefits might be for
And,
me?
the 52-year-old who's still getting her period and had a heart attack 3 months ago is
Right?
certainly a worse candidate for starting hormone therapy than the 62-year-old who had her last period 5 years ago, runs marathons, and has a BMI of 18, right? Like they're very different people, and one is not just because of her age unhealthier than the other.
Yes. So, Michelle, you have played a leading role in menopause care in Canada for quite some time, and your role is changing. Tell us about that.
Thank you. Yeah, it's an exciting time for me. I mean, I feel like I'm in a support group too. Like I'm Michelle and I'm perimenopausal. But I have been doing menopause management as a specialty for about 10 years. So even before it was cool, I like to say. And a lot of what I have focused on and cared about was treating menopause, but also menopause in very complex women. So women with
Yes.
medically complicated histories, women with transplants, women with cancer who are in menopause because of cancer treatment, and women with hereditary breast and ovarian cancer genetic conditions. And I've really, really learned a lot. I've loved what I've done. I think I've helped a lot of women. But what I am seeing now is a real gap in quality care being delivered to the healthy perimenopausal woman or early menopause or late menopause woman who finds that menopause is being talked about and she is trying to weed through so much misinformation and get access to care. So my business partner, Jennifer Patterson, and I started Coven. Coven is a virtual virtual, collaborative, multidisciplinary clinic that is really meant to help you access the care that you need in a way that is reliable. So you will know that you are getting evidence-based care and individualized care. I have developed all the programs and curriculum. We handpicked our team, which includes not only nurse practitioners to deliver the medical care, but registered nurse health coaches or menopause navigators to help weed through the journey, a registered dietitian who is phenomenal, social worker to help with all of the different mood and mental and emotional aspects to the things that bother you in menopause, whether it is your mood, your hot flashes, your weight, whatever the thing is that's on your mind that is bothering you the most, we are here to support libido. And my personal belief is that we've not done enough in the medical world of just listening to you and treating the symptom you presented with and saying, go get some therapy also and maybe talk to a dietitian. You need people who are working together, who are communicating with one another. That is what coven is meant to do. A coven is traditionally a group of witches, and we think that it's time to reclaim the Salem witch of the 1600s, probably the most interesting, spicy perimenopausal woman around. We don't think you should be burned at the stake. We think you should be part of a community. And that's really what Coven is meant to do.
That's so beautiful. It's so beautiful. And what you're doing, I mean, is trailblazing. We're creating new access to care, as we mentioned. So I just want to make sure that everyone understands because um, I'm going to say wait list.
Yeah. So within my provincially covered, complex menopause clinic, my wait list is, and I'm embarrassed to say this, 2.5 years.
Right.
And
We know.
that is
We know.
not because I'm not working, right? It's not because
Right.
I'm golfing. Shirley and I are chatting on Sunday morning because there was no time during the week because we're all working so hard.
Yeah.
And yet, I can't keep up with this demand. Coven is meant to be a curriculum and a protocol and a program that I can educate others and we can grow as we need to keep up with the demand. I can't
Amazing.
see everybody myself.
Yes.
Obviously, that is what has led to a 2.5 year wait, but I can disseminate my knowledge and my approach, which I hope people think is good, and make access to care more efficient and know that the same messaging that I'm giving when I see my patient can be duplicated and repeated on an individual level for every patient who needs to see us and doesn't deserve to wait 2.5 years to be seen.
Exactly, exactly. And we just, we would love to see you, but it's also great to know that when we sit down with a practitioner, maybe a nurse practitioner, another prescriber, that they've been trained by you or that they're a colleague of yours. And so, what we're actually doing is building those branches so that when the next generation comes up, there's actually more access to care.
Exactly. Like that's the thing is I can teach these nurse practitioners everything that I know and help them and guide them through their approach. And they are outstanding. They also bring something to the table that I don't because I am a gynecologist and a menopause specialist, but nurse practitioners have actually been trained in a very broad way. They do a lot of primary care. So
Yes.
when you have questions about your thyroid or your weight or your blood pressure, I would have had to lean on a primary care colleague or an internal medicine colleague. These NPs that I'm able to sort of elevate their menopause knowledge and perimenopause knowledge come with a really robust set of primary care knowledge. So I think it's actually an outstanding delivery system
Yeah,
of
yeah,
good
that's
care.
beautiful. Could you just speak for a minute to the difference between when is menopause primary care and when is menopause complex care?
Yeah, also a great question. And I think that really depends on the comfort and the knowledge of the primary care. For most of, your first entry into talking about menopause with your care team will usually be with your primary care, although it could be with your oncologist. Let's say if you're a breast cancer
Right.
survivor, it's going to be who the person that is looking after you primarily when your symptoms start to be bothersome. And then it becomes a question of how comfortable are they, how well versed are they in treating menopause, given the nature of the problems that you are presenting with. So, for women who are otherwise healthy, who are average aged for menopause, who have not had major cardiovascular events or blood clots or cancers, it ought to be your family doctor, your nurse practitioner who can address your menopause. That being said, we are coming off of a 20-year gap of educating family doctors. That is a product of the way the WHI was publicized and the nature of the last 20, 25 years of teaching. So, as much as I wish every family doctor knew more and was more comfortable, they aren't. And that means that unfortunately, that referral needs to be made, even if it ideally would be done within a primary care setting.
Yes, amazing. And the message that I'm taking away from that too is that we have access to care no matter where you are on that spectrum.
100%. Like if you're looking for provincially covered care, you see your family doctor. They can certainly refer you to a menopause specialist if there is one in your community. If there isn't, you're a little bit more needing to travel, which I think is highly unjust and unfair. If you don't have a family doctor or you feel that your family doctor, your primary care practitioner is a barrier or an obstacle in your journey, Coven, for example, is completely self-referral. You don't need a referral from your family doctor. You can just sign up yourself. And I think that that is pulling down barriers for women who are looking for care.
Yes, yes. And on the complex end of things, maybe you were told, maybe you survived a cancer experience a few years ago and were told nothing for you, like that's it, right? And now it's like, no, maybe there's a window of opportunity for you to have an investigative conversation because you deserve
Yeah.
to feel well.
First of all, yes, like what you were told may or may not be true. Ideas are evolving. But even if you ought not to take hormones, there is a host of other treatment options. And to ignore your menopause symptoms because you can't take hormones is really unfair and oversimplifying. Like
Yes.
you can see us and we can talk to you about hormones, but also about 100 other options that may still lead to your health, your quality of life, your feeling powerful. That is what menopause care is about. Menopause care does not equate to only hormone therapy.
Amazing, amazing. Can I keep you for one more question?
Of course.
We haven't made the distinction between systemic hormone therapy and vaginal hormone therapy, and that is often confused. And so when I have this opportunity to speak to one of Canada's leading menopause doctors and gynecologists, I cannot leave without talking about genitourinary health.
100%. Remember that systemic menopause symptoms are going to be the things like hot flashes, night sweats, not being able to sleep, low libido, mood symptoms, palpitations, joint pains. Many of those can be helped by systemic hormone therapy, which means taking estrogen by mouth or through the skin with some form of endometrial protection. But the genitourinary syndrome of menopause is a problem that affects probably up to 80% of women or more, is highly
If we
under
live long
talked
enough.
about. Yeah. And is the type of problem that develops more the further away from menopause you get. So, unlike those restrictions with starting hormone therapy we talked about before, where you should ideally be under 60 or less than 10 years from your final period, there is no restriction on age limit or timing from period to start treatment for your local symptoms. And local means pain with your vulva, bleeding after sex, dryness, itching, overactive bladder, recurrent urinary tract infections. All of these, this constellation of lower genital and urinary symptoms can be treated with local therapies, whether it's estrogen based, testosterone based. There is one oral option as well that is still considered for treatment for the GSM symptoms, and that can be initiated at any time. There is no limit, and it should be. This is a chronic condition.
Totally. Take that message, go tell your mom and your sister and your aunts and spread it around.
Yeah, local hormone therapy in the vagina for everybody.
Love it. Listen, I'm so grateful that you are doing this work. You've been doing
I'm
this work for a long time, but this new step into the coven experience, I know that just so many more women are going to leave that experience feeling validated and heard, and that is one of the number one goals of Menopause Chicks. So we thank you.
Well, I
You're just
thank
getting
you.
started. You're
This
just
advocacy you
started.
have done is so appreciated, so needed, so admirable. I think we should actually be very grateful for Shirley and the community who support you and who you support because you keep us going. You give us a reason to keep going.
Yay. Okay, tell us how we can find you.
Find us at www.covenhealth, covenhealth.com.
Thank you, Dr. Michelle Jacobson. I know you have to go on vacation, well deserved, and we will talk to you soon.
Thanks, Shirley.
Bye.
Bye.